Good morning, good afternoon, everyone. So the next session is equity and access to healthcare. So my name is Ken Taneda from Japan, currently working for National Institute of Public Health. My institution also WHO collaborating certain. I also worked for the WHO Western Regional Office before as the patient safety officer. So it's my great honor and privilege to be moderate this session. And the first speaker is the Dr. Mondale again. He's just quite popular and very busy today. So he will talk about the universal health coverage, moving towards better health. Please join me welcoming Dr. Mondale.
Thank you, Dr. Taneda. Thank you. It's my pleasure again to share with you this presentation, which is about the universal health coverage. So as you know, the universal health coverage is embedded in the SDG agenda. Under the SDG 3, good health and well-being, and the target number 3.8, which is to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccine for all. So what universal coverage is? So it is commonly presented as the provision of healthcare to everyone in society in ways that protect users from financial hardship. There are concerns regarding the cost of healthcare, reflecting growing evidence of the role of healthcare cost in preventing access to health services, especially for the poorer social groups and perpetuating poverty. International recommendation for achieving universal health coverage focus on beginning with the provision of a basic package of health services that can be provided universally and free of charge, and then subsequently expanded to include a wider set of services. So here we have the universal health coverage cube, and we have three main pillars. In the universal health coverage, we have the population coverage, how many from your population are covered. We have also the service coverage, the basic package of health services, what services are covered by your universal health coverage program, and the financial protection, what is the payment, the financing mechanism that is considered in your program. So the universal health coverage will aim to extend to the non-covered, also to increase also the number gradually, the number of services to be covered, and also to reduce the direct payment from the population. So we have this equation that includes the three parameters: the population coverage, the service coverage, and the financial coverage, payment contribution. And you can easily understand that the quality should be there embedded in the universal health coverage. Why? Because if you increase access without quality, people will not use your services. And this has been demonstrated through different reports. People will flee your services because they will not feel safe when using your services. So one key message is to make sure that in the development of your universal health coverage program agenda, there is a specific attention to making sure that quality is there in terms of access, the user satisfaction, in terms of clinical quality and patient safety, and in terms of equity and efficiency of the service. What is needed to achieve universal health coverage? You need a strong and efficient, well-run health system that meets priority needs. So informing and encouraging people to stay healthy and prevent illnesses, detect health conditions early, having the capacity to treat disease, and helping patients and rehabilitation, ensuring sensitive palliative care where needed. So your services should cover the whole continuum of services from promotion, prevention, treatment, and rehabilitation. The affordability is also very important. So the capacity to pay for the services and the system for financing health services so people do not suffer financial hardship when using your services. The availability of essential medicines and technology, an efficient capacity of well-trained and motivated health workers, and actions to address social determinants of health such as education, living conditions, and household income, which affect people's health and their access to services. This is the global monitoring of progress towards universal health coverage. There are indicators that are used to monitor, and we have the indicator 3.8.1, which is about the coverage of essential health services, which is the composite of 16 tracer indicators that define the service coverage. Also, another indicator is the proportion of a country population with large household expenditure of health, a share of household total consumption or on income. We have more than 10% or 25%, depending on financial hardship or catastrophic expenditure. At regional level, we have this framework on how to advance the universal health coverage agenda in the Eastern Mediterranean region. But in general, we have three main levels, in addition to the policy level. At the policy level, we need to have like a vision and a strategy for universal health coverage. Then we have three levels, three different streams. One is in relation to the enhancing the financial protection. The second will be on expanding coverage. And the third one is in the expansion of population coverage. Regarding the vision, when starting the work on the universal health coverage, there are some activities that can be conducted by the countries and others that define the role of WHO. Examples of activities, like, for example, conduct a health system review. We need to start with a review of your health system in order to understand how the situation is going in terms of to assess the status of financial protection, service coverage, and population coverage. Then establish a multi-sectoral steering mechanism. And here there is a role to play by the advocacy association in terms of advocating and making sure and contributing to the different discussion on the universal health coverage. Developing a roadmap for USC, and there is a need for input from the civil society and the NGOs. Like, for example, in some of the countries, there is like a societal dialogue with the different stakeholders in order to make sure that the roadmap will include the inputs from everybody. Establish and strengthen USC coordinating and implementation mechanism, and promote applied research for USC. And this is also key and very important to see to what extent the developed interventions are able to move forward with the USC journey. Some activities are to be provided coordinated by WHO, generate and compile evidence from other experiences, international experience, facilitate national policy dialogues, and provide technical support for the establishment of a multi-sectoral steering mechanism. For the financial risk protection, review the health financing, establish prepayment arrangement through an insurance, for example, including social health insurance and general revenue taxation, for example. Establish and strengthen independent or quasi-independent purchasing body. In terms of universal health coverage, there is a rule of the three things, then the collecting, pooling, and purchasing, making sure, and this will ensure better efficiency for your financing mechanisms. For WHO technical support, We have tools that can be used in terms of surveys that will tell you to what extent you are, where you are in terms of financial coverage. Prepare implementation manuals of prepayment arrangement, or develop and disseminate information products on innovative financing approaches and communicate evidence to policymakers. Expanding the coverage of needed health services as example of activities to be conducted by the countries. Design and implement a package of essential health services, and we are supporting some countries on the development and adoption of their package of essential health services. Improving the quality, safety, and continuity of care, and strengthen the engagement with non-for-profit and for-profit private sector in service provision in support to universal health coverage. And the role of WHO will be to develop a regional roadmap to support the establishment of effective replicable family practice program as a model of the delivery of care, develop and disseminate guidance on family practice and building capacity. Because, you know, one of the key pillars for universal coverage, key recommendation, the driver for universal coverage is the primary care. And in the Eastern Mediterranean region, the model of care for primary care is the family practice. We have been now supporting many countries on how to scale up the primary care through the family practice model. The expansion and monitoring of population coverage, progressively expand coverage to vulnerable groups. And this is very important because, you know, in the Eastern Mediterranean region, we have many countries that face adversities, conflicts, and wars. And these are vulnerable settings. So we need to make sure that the coverage to these population is included in this agenda. Collect data disaggregated by income region to make sure that we are monitoring the equity issues in terms of access to quality health services. What can be done by WHO? Share experiences from countries and develop a framework for monitoring population coverage and USC. The essential package of health services, what is it? So the essential package of health services or health benefits package is a set of prioritized health services publicly financed through a USC scheme. So we need to agree there is a whole process the country can start with in terms of analyzing the situation and conducting different discussions, and based on the evidence from the epidemiologic side, from the input from the different stakeholders, and agree on the priorities. And based on the priorities, we will define the different activities, and we will cost this priority benefit package in order to ensure access to this priority benefit package by all. So it helps in addressing the high burden of the problems. It's cost effective and to select the cost effective interventions, promoting equitable access and ensuring the efficiency of resources and minimizing budgetary impact. The objective of the essential package of health services. So we have the design of the essential package of health services. There are different elements to be considered. And one of them, which is very important, to have explicit objectives associated with the essential package of health services. And with this, we need to have the financial protection, the health status, the beneficiary satisfactions, the equity in access and financing, the efficiency, and the quality of care. The universal health coverage in fragile and conflict affected. As I said, in our region, we have many countries that face urgencies and adversities. So we need to make sure that universal health coverage agenda will not leave behind those what are vulnerable. So we should recognize that there is a limited ability to extend coverage due to fiscal governance constraints for governments. This is something that is also very important. Sometimes governments, they have faced difficult decision on which services to offer free through public health systems and free, and from there how to transition to healthcare given the limitation in terms of resources. Implementation problems due to the capability to manage and regulate providers, because the role of the government in settings of adversities, conflicts, will not be strong enough to make sure they are controlling all providers. sectoral distortions in the health system resources. For example, the workforce migration to NGOs and private sector, because in a situation settings of adversities, some of the donors will treat through the NGOs, will contract through the NGOs, and the NGOs will be paid by, like, for example, UNICEF in Afghanistan. So we need to make sure that this kind of problem will be taken into consideration. The poorest should be given priority for coverage by healthcare services, and in settings of adversities, many workers will work in the informal sector. So how to make sure they will have access to free services in this situation, or mobile population due to the fact they are moving from a place to another due to the conflicts. The civil society provides an important mechanism for ensuring that health budgets are equitable and that socially excluded groups can access healthcare without risking financial hardships. So the take-home messages: universal health coverage has a direct impact on a population's health and welfare. The access and use of health services enable people to be more productive and active contributors to their families and communities. Universal health coverage is a critical component of sustainable development goals and poverty reduction, and a key element and any effort to reduce social inequity. Universal health coverage is the hallmark of a government's commitment to improving the well-being of all its citizens, and equity is paramount. Countries need to track progress in providing access, not just across the national population, but also within different groups, example, by income level, sex, age, place of residence, migrant status, and ethnic origins. So with this, I reach the end of my presentation, and thank you for your attention.
Thank you very much. Very informative presentation, Dr. Mondale. So next speaker is the Miss Christine Elvazio. Sorry, Candice. I'm sorry, Miss Candice Henley. She unfortunately is not here, but she has provided us the recorded the presentation.
She is online and she will be available for answers.
Good morning, good afternoon, good evening, distinguished guests, healthcare professionals, and fellow advocates, both from the United States and the international arena. My name is Candice Henley, and I am the Director of Equity and Partnerships at the Global Colon Cancer Association. It is both a privilege and a profound responsibility to speak with you today as both a patient and an advocate to address an issue that is not only critical, but also deeply personal to myself and other individuals across nations. A topic that should resonate at the very core of our resolve and collective humanity: equity in healthcare. Healthcare equity is not a novel concept, but its implementation remains one of the most daunting challenges of our time. It is where the sanctity of health intersects with the complex layers of social justice. Equity in healthcare means that everyone has the right to attain the highest level of healthcare and health, irrespective of their race, ethnicity, and social economic status. Yet, here we stand in a world where the disparity gap is not just evident, but it is widening. For too long, our healthcare systems have operated under the shadows of disparities, where one's race, ethnicity, socioeconomic status, or geographical location determines the quality of healthcare they receive. But the tide is turning. Today, let us take a profound journey to understanding these disparities and identifying root causes, and most importantly, forging a path toward a future where healthcare is not only ideal, but a reality for all. From a patient standpoint, healthcare is not just about treatment. It's about dignity, it's about respect, and it's about understanding. It's about not having to fight to be heard within the very system that is supposed to heal. Patients from historically minoritized communities often report feeling disregarded and misunderstood by healthcare professionals. I know I did. This isn't merely discomforting, but it can be life-threatening. Misdiagnosis, delayed in treatments, and inappropriate medical advice. These are real consequences of a system that has yet to align its practices with the needs of its diverse patient population. Imagine needing life-saving screenings, but the nearest facility is miles away with no accessible transportation. Picture a mother juggling 2 jobs who cannot afford to take time off work to visit the doctor for preventative care. Think of young people who have yet to have insurance and cannot access healthcare due to cost and fear and shame. These are real faces behind statistics and their stories. Our stories must steer the ship of change. And as advocates, we stand at a critical nexus between the patient experience and systemic change. Our role is threefold. It is to amplify the voices of those marginalized in healthcare conversation, to educate stakeholders about the importance of cultural competency, and to push for policy reforms that mandate equitable health practices. Our advocacy is grounded in the belief that understanding cultural nuances and medical history is not elective, it is essential. It is what bridges the chasm between patient suffering and provider understanding. It is what transforms healthcare from a privilege for some to a right for all. It requires us to not only speak, but to listen to the whispered needs of the marginalized, to the silent pleas and cries for help. It calls for collaboration across sectors, from grassroots organizations to the highest governmental bodies, to ensure that policies are not just inked on paper, but they are brought to life to the very communities that need them most. It involves educating researchers and doctors on cultural competency, advocating for the future of medical history to be inclusive for all narratives, and demanding that research reflects the diversity by which we uphold and by which we live. Advocacy means being a bridge, a conduit of understanding between the often sterile world of medicine and medical data and the richly textured fabric of individual human experiences. The pursuit of equity in healthcare is not a solitary endeavor. It is a chorus that needs every voice from every corner of the globe. The disparities seen here in Chicago are echoed in the slums of Nairobi and the rural landscapes of India. The lessons are universal. The solutions, however, need to be localized. International solidarity comes from shared learning, from a mutual exchange of strategies that transcends borders. It is about recognizing that while the specific healthcare inequality may vary across geographies, the underlying currents of poverty, education, discriminations are strikingly similar. And without addressing these factors that drive health disparities, we cannot achieve health equity. Addressing this requires a multifaceted approach of strategies. It calls for investment in education and community engagement outreach programs that target health literacy. It necessitates infrastructure development that does not overlook the underserved. Policies must be designed with an equity lens, ensuring that screening programs, for example, are not just available, but are accessible to those who need them most. It requires building a healthcare workforce that is as diverse as the population it serves, one that is trained in cultural competency, and one that understands the social determinants of health. We must push for more funding and research that prioritizes diseases disproportionately affecting minoritized communities and insist that these studies are carried out by a diverse team of researchers. In closing, equity in healthcare is more than a goal. It's a journey that requires a collective effort of patients, advocates, healthcare providers, policymakers, and society at large. We have power to write a different story, a different narrative, a narrative of hope, a narrative of resilience, and of a world where equity in healthcare is not just the exception, but it is the norm. As we stand united, let us be reminded of the words of Dr. Martin Luther King, who said, "Of all of the forms of inequality, injustice in healthcare is the most shocking and the most inhumane because it often results in physical death." Thank you, World Patients Alliance, and thank all of you for your commitment to this cause. The road ahead is long, but together, we can build a future where equity in healthcare is the cornerstone of our global community. May our discussions today be as transformative as the actions they inspire. Thank you.
Thank you very much for a very rich, in-depth, and very passionate presentation. Candice, are you with us right now on virtual?
I am. It won't allow me to turn on my video.
When we need your question, we will make you the call.
Well, just I'd like to ask the Candice if you have some additional few words to our participants in here and also the virtual.
Oh, absolutely. I think we are, as advocates, we are in this work and we bring our hearts.
You can start your video.
I'm sorry.
You can start your video now.
You can turn on your video, then we can see your face.
Hi, everyone. Good morning. I'm sorry that we couldn't be there, but I just want to say thank you all for all the presentations that I've heard. As advocates, this is such passionate work because we bring our heart and as a patient myself, learning the landscape of the challenges that other patients face around the globe has been the most rewarding for me to learn, because I always say you never know what your neighbors are dealing with until you find out and until you ask. And once you ask, a lot of times you realize that, oh my God, even in the privilege that I think that I don't have, I do. And so I bring my compassion and I bring my fight for those who no longer have the voice or who have never had the voice, because that is important.
Thank you very much. So please give a big hand to her again.
Thank you.
Thank you. Thank you very much.
Thank you.
So, yeah. Then I'd like to introduce the next presenter. So Ms. Christian, okay, she is with she is with us, right? So please take a floor.
Good morning, everyone. So this is Christian Persdi. I'm from Children Cancer Center of Lebanon. I will be presenting the emergency preparedness in the Middle East as a surviving chaos. This is mainly the outline. And as an introduction, emergency preparedness is a continuous process in which action, funding, partnership, and political commitment must be sustained at all levels. It highly relies on all stakeholders working together effectively to plan, invest in, and implement priorities actions. The main objective is to explore, examine, and understand why emergency preparedness is essential in the Middle East, and now how we can take steps into be better prepared in the future. Maybe this slide, it shows the current situation. So as you all know, Middle East, it hosts the largest number of internally displaced population, and we have around 30 million people displaced, 2/3 in their own countries and around 1/3 in other host communities. So, for instance, the registered Syrians in refugees in Lebanon, they count for 1/3 of the total population, which is 4 million. We have also around 18 million people requiring humanitarian assistance. And this is putting both displaced population and the host communities at all kinds of risk due to the conflict in the region. The unpredictable nature of emergencies can often be chaotic and confusing, that even with the best preparation, it can be difficult to anticipate exactly what will happen and how to react to it. So it is crucial that we address this issue and work towards building more resilient communities in the Middle East. The challenges faced are mainly categorized into three. So we have the first is the natural challenges faced with the most common drought, earthquakes, floods, sea level rise, sandstorms, wildfires. And the less common, we have volcanoes, landslides, tsunamis, and cyclones. The human-made challenges is the second category. We have ongoing conflict, insecurity, terrorism, violence, and war, which is happening right now. We have the economic crisis also is happening right now, inflation, unemployment, displaced populations and overcrowding, limited access to basic needs like food and clean water. We have also other barriers such as strained transportation and communication barriers. The third challenge faced is at the organizational level. So we have insufficient policies and legislation, intra-agency coordination. We have the scarcity of resources, mainly medical supplies and essential medications. We have also disease outbreaks due to healthcare gaps, limited access to primary healthcare, knowledge and experience deficit of the healthcare worker, mainly brain drain, because the healthcare workers are looking for better quality of life in other countries. We have absence of contingency plans and inadequate training, and lack of data for reporting and analysis. The level of disaster management is mainly, it consists of three main levels. So we have the national one, which is at the governmental level, and the local, here comes all the NGOs like the WHO, the Red Cross, who are like involved in evacuation, managing medical supplies, and rehabilitation. Finally, we have the health authorities like public health issues, clinical setup, and etc. So it's very important that we strengthen our health system by continuously improving these pillars because they are interrelated. So we have leadership and governance, and here it's very important that we set strategies based on evidence-based practice. And trustful sources, we have human resource, access to essential medicines, service delivery, financing, and information systems. The strategic framework of emergency preparedness plan, it's a continuum mainly that consists of 4 phases, with phase number 1 and 2 are the most important ones. Phase number 1 is the prevention and mitigation, which is we're trying to reduce the risk, especially if we have no resilient infrastructure. The second is preparedness. Here, like we try to give early warning system before the incident, so we see how prepared we are. And after the incident, we have phase number 3, which is the response. Here it talks about life-saving mainly, integrated response in accordance with the strategic priorities. And finally, we have phase number 4, which is the recovery and reconstruction. We can see at the core of this wheel, we have key elements, which is environmental scan, leadership engagement, risk assessment, training and exercise, capacity building, and performance assessment. Here are some tips on how we can be better prepared. So it's important that we ensure building a resilient infrastructure design. We have to set multiple channels of communication and network to ensure that information is disseminated quickly and effectively, such as phone lines, media platform, etc. We need to establish robust early warning system for disasters or emergencies. We need to raise awareness about potential risks and educate communities on how to respond to emergencies. We need also to establish partnership and collaboration between different organizations, governmental agencies to ensure a coordinated response in time of crisis. We need to be open to collaborate between international organizations and neighboring countries to share resources, expertise, and support during large-scale emergencies that may cross borders. It's very important that we update the local rules and regulations to incorporate lessons learned and enhance disaster preparedness and response measures. Finally, we need to provide mental health services and psychological support to individuals affected by the emergency. We must also consider stockpiling supplies like food, water, medicine, medical equipment. We need to have a solid strategic plan, and we need to set and implement contingency plans for emergency situations. Finally, we need to consider environmental sustainability, cultural, and other religious or ethnical considerations. I'm going to be sharing with you a real case study that I personally have witnessed in Beirut. So it talks about Beirut explosion on August 4th of 2020. On this day, a major explosion took place in Beirut, which is the capital of Lebanon, where I come from. It was one of the biggest non-nuclear so it was one of the biggest non-nuclear explosions in history. Approximately 2,750 tons of ammonium nitrates stored in a warehouse at the port. When it exploded, it caused extensive damage over the entire capital and was felt in nearby countries. The blast resulted in 30,000 people displaced, 8,643 injured, presented to emergency departments at different hospitals. So this is a case study, or mainly it's an assessment to a response that the main hospital in Beirut did. And they identified three gaps. So first, it was at the explosion happened at 6 p.m., which is most of the personnel, they went home. So by the time they came back, the medical student and whoever was there, the essential workers, they had to manage all the casualties coming at the emergency department. And so it was communicating with each other was mostly hardly possible. And they could not identify each person's assigned to their location, allocated zones. Or even the triage, it went out of the emergency department. It was fully occupied, so they were treating casualties in parking lots. Moreover, they failed, the electronic system failed, and they could not identify patients and tag them. So they ran out of bracelet tags. And the security, they could not handle the crowd at the front door of the emergency department. It was people they asking about their relatives, casualties, and they missed to document who they treated. So it was really bad. Finally, they identified the need of having collaboration with a different hospital network system, which could facilitate a transfer in a mass casualty incident. This is the CCL response, which is where I work, the organization that I work for. I'm going to be sharing with you a short video. Harris.
Few minutes past 6 p.m. on Tuesday, August 4, 2020, Beirut witnesses a massive explosion originating from its port and devastating so many lives around the country. To date, at least 220 dead, more than 6,000 injured, and over 300,000 homeless as a result of this destruction. Several hospitals around Beirut were severely damaged due to the proximity from the explosion site, and the Children's Cancer Center of Lebanon, CCCL, facilities at the American University of Beirut Medical Center suffered material damage of ceilings, walls, floors, glass windows, doors, furniture, and equipment. The CCCL supports almost 40% of kids with cancer in Lebanon at the American University of Beirut Medical Center and other hospitals. Damaged hospitals in Beirut jointly care for around 25% of all kids with cancer in Lebanon. As a result of the destruction and prevailing Lebanese economic and financial collapse, we are facing high risks preventing most childhood cancer patients from accessing adequate treatment. To mitigate these risks, and despite all the difficulties and hardships surrounding us, the CCCL Chair and Board of Trustees have taken the lead and pledged to support all kids with cancer in Lebanon. The CCCL will play the facilitator role, coordinating and providing solutions and coverage for the doctors and patients who cannot get the treatment at the ruined hospitals, and will expand support to medications, medical supplies, and psychological follow-up. This is our relief response, addressing and mitigating all risks preventing pediatric cancer patients from adequate treatment in Lebanon until end 2020. An estimation of $2 million are needed to fund our relief response, and donations can be made through www.cccl.org.lb/rescue-fund. Our commitment to the childhood cancer cause and resilience remains strong because cancer doesn't wait. From Beirut to the whole world, we thank you for your contributions.
Thank you. So as for the governmental response, it was widely being criticized as being slow and inadequate. But however, the Ministry of Health, it declared treating all injured citizens at its own expense. However, it was really not at the level required. In conclusion, research should focus on identifying factors that influence emergency preparedness for disasters among hospitals in the Middle East to develop multidisciplinary approaches to improving emergency management in the region. And it is crucial that that individual organizations and governments take an active role to successfully implement an emergency preparedness plans. So these are my references, and thank you.
I'm going to ask you whether they have. Thank you very much for very invaluable sharing, invaluable experiences. I think this is a very the rare opportunity for us to learn from your experiences. So I'd like to ask our participants in here if you have any questions. Maybe we can take a couple of questions for her right now. I have one quick question. So here we have a lot of patients, family, community representatives here. So you want to that share, the take-home message to them based on your experiences. Yeah.
I believe we need to have political commitment to enhance the capacity building and ensure a surveillance system, and mainly we need to raise awareness to the community to be very well prepared, because as you show, we need to have rules and regulations. We could have avoided this if we had stored the ammonium nitrate properly. So this is very important that we document, we raise the awareness, we look into research what our, for example, we can rely on other transfer source like WHO. This is how we can, if we don't have a resilient infrastructure, we can work on reducing the risk. So, which is phase number 1 I talked about.
Thank you.
Thank you.
So thank you very much. So please give a big hand to her. Thank you. So if you have any further questions to her, please let us know, and we can maybe convey your question to her and ask her to answer to the questions. So the next session is the panel discussion. First of all, I'd like to invite all panelists to the front table. Then I will ask some questions to each panelist. So please sit on the table in front here. So as panelists, we have today here Mr. Anas Nopal from UAE, and also Ms. Farij Sakur from Kuwait. So first of all, I'd like to invite and also, let's see. also Mr. Edmund Lau from Singapore as well. Thank you. So I'd like to first of all invite Mr. Edmund Lau from Singapore. And then I'd like to ask you the one question first. So what is the most significant barrier that currently contribute to the disparities in access to healthcare services? And what strategic initiatives are being implemented in your country? So you can, please come over to here. Yeah, then people can hear very well.
Sure. Good morning to everybody. My name is Edmund. I'm from Singapore. I'm representing the Psoriasis Association of Singapore. And of course, it's very great that Hussein has invited all of us to come here to have a face-to-face discussion. Now, first of all, I would like to say a big thank you to our speakers, Dr. Mondel, Candace, and of course, Christian, to talk about the situation in the respective country. So again, very importantly, we also talk about the World Health Organization. So the key thing about access itself, right? We earlier learned that according to, my apologies. Okay, my apology. All right, now according to the Universal Healthcare Cube, that's what we have learned from here. So generally as a patient, we hope that every patient is accessing safe, quality, and affordable healthcare services throughout the international healthcare value chain. So again, we have to address this very important concept here. We talk about the whole healthcare value chain. We have to talk about the primary services as well as the supporting services. So as a professor teaching at university, we talk about Michael Porter. We always talk about a 5+4. So the 5 primary and the 4 secondary services that we want to deliver in a proper international value chain. So this is one of the key things that I would like to really learn a lot more from our speakers. How are we going to integrate this into the value chain? And from what we have learned, also at the same time, World Health Organization have a variety of priorities that contribute to the global health development when we talk about access to healthcare. Now, one of them is about public health, preparedness, and response. So how do we respond to pre-COVID or pandemic, and now we may say it's post-pandemic? So how do we really integrate this? Because we are living in 2 different worlds at the same time. Now, secondly, we always talk about a world global population. As we know, as of today, we have about 7 billion people in the world. If we were to separate them into the global north and the global south population, you're talking about 3 billion and 4 billion. 3 billion global north and 4 billion global south. So again, how do we get access to it accordingly, and what is a priority? And don't forget, by the year 2050, we are talking about almost close to 10 billion people in the world. So where is the breach and the gap that we are going to address? That will be another key challenges. That's the first point. And of course, the second point is about the disease eradication and control. So this will be a lot of R&D work to be done by all stakeholders that's involved. So again, we talk about polio, tuberculosis, or even HIV, malaria, and some of the neglected tropical diseases. So coming back to our association, psoriasis. In this world, we have close to 125 million cases. And you know, this is a chronic disease that many of us have been suffering, perhaps from childhood. And it's really a big impact to every one of us. And in Singapore alone, we have 40,000 patients living with psoriasis. So as advocates, we are trying our very best to create the kind of awareness to share with people, especially the message on psoriasis is not contagious. So we have been trying to use this, in marketing. We always talk about the IDA model, right? So you create awareness and then you generate interest. And at the same time, you're going to have the desire to take action. So how are you going to put all this pillar into action and then address this with a goal? All right. So again, we talk about a goal, we talk about the SDG 3, as what we were talking about just now, out of the 17 goals that UN has created. So I was just wondering, for UHC to materialize, universal healthcare, are we going to have this umbrella which can be used throughout all continents of the world progressively? And we are going to have our milestone being set up. But WHO, of course, we need WHO to lead, all right, at the same time. So again, how is this being advocated from the pyramid, from the top to the lower level, progressively? All right, and finally, of course, we talk about data analytics. So we need evidence-based research, and hopefully we are able to work with the academia and the non-academia, the government agencies, and all stakeholders. And my departing word is this: I hope every patient, again, one more time, is able to access safe, quality, and affordable healthcare services throughout the international healthcare value chain. Thank you so much, everybody. Have a good day.
Thank you very much. So next, I'd like to invite Mr. Anas Snowfall from UAE. And the question to him is, how can patients' accessibility to healthcare services lead to meaningful changes and drive healthcare system improvements? Mr. Anas.
Hi everyone, good morning and welcome to our lovely city, Dubai. And thanks for the World Patient Alliance for the invitation. Well, I believe if anyone counts how many times they mention access today, I'm not aware about yesterday, but a lot. If anyone know how many they count, I'm happy to give a gift. I am from military background, 10 years back, and usually I like to define things. So can anyone define access in healthcare? And Mr. Hussein will give gift, not me. Anyone has a definition? Why not? Yes, this is part of it. Let us think. I know you are sleepy like me. Well, this is the first thing I have done when I joined the industry of access, is to understand what's the definition. And 13 years back, I find a definition in healthcare saying that access is how we could let the right patient. So we need to have technology, we need to have screening, we need a lot in place to be able to reach the right patient. If we are enable the right patient to reach the right treatment, so we need to have the availability of this right treatment. It could be a surgery, it could be educated physician, it could be medication, and we know that 70% of our main issue is medicines and medication. And to be able to be treated, I could treat them, but 10 years later, imagine a psoriasis patient live with psoriasis, and he will not get married. By the way, I get married newly, so it's not easy to get married and have the female acceptance these days. So the social stigma of this psoriasis patient, there is a lot will happen if it is not on the right time and in the right way. And here where the equity it comes in the right way. I mean, it is sustainable. I don't give to the half of this group and the rest of the group, I don't give to them. It should be compliant. It's not coming from money laundering. because it will not be sustainable. I will not give it for many years. So this was the definition actually 13 years back, and we have changed it recently, saying how we could let the eligible human or all human, because when we do screening, we are not screening actually patient, we screen communities, we screen public. And we are saying again, it is to reach the right or the high quality healthcare services on the right time. The timing, it is very important, because now viruses, they don't have hour actually. They don't wear Apple Watch. And at the same time, there is no border on the viruses. And this is what COVID teach us. And very important as well, it is sustainable. Sustainability, it is always there, but it should be convenient and customized. And this is what we have changed in the new definition. And customized because cultural aspect, it is play a role. We as Middle Eastern, we are very straightforward. If we are angry, we will say that we are angry. In Asia, I go on a trip in Malaysia, Singapore to manage my offices there. And the people, they were happy. Okay. Next day, nothing happened. So understanding the culture, even when you are providing the treatment, it is very important. Now, what will happen if we have access? I believe all the people answer you that if we have access, we achieve the ultimate goal of the service provider or the healthcare. Why we have healthcare? Is maximizing medical benefit. But without accessibility, we will be what we call a CNN bad news breaker. Imagine me, I know many physicians. I am managing 35 countries and now almost 62 countries. And always when I visit any KOL, we call it in physician, means physician, key opinion leader physician. And I know many physicians, they close their door because there is no treatment accessibility because of the economic crisis, devaluation happened. They cannot treat patients. Anas, what I will do to the patient? I will say to him, okay, you have psoriasis, you have ankylosing spondylitis. Okay, doctor. No, you have that. Without treatment, without providing the solution, I believe the burden of the disease, and better not to say to the patient. Two story quickly. One story happened in Rwanda when we are screening for mother to child HIV transmission, and we say to the mother, oh, you have HIV. Okay, what's next? The antiretroviral, that time it's not accessible for people in Rwanda. And it took from the team where they were US aid team, evacuation by military. Because we give bad news to the community without a solution. So accessibility, it is the solution. There is a lot of technical part to play in accessibility, the political aspect, the regulator. But I want to tell you a story, and it is happening from many nearby country related to accessibility. The second biggest provider after the Ministry of Health for 3 million as a population. Like there's 1 million, they have the coverage, and 3 million, the coverage, it is coming from charity. And this charity used to buy biological treatment for almost 400 psoriasis patients. They buy 8 and they get 4. I visit them and we say, we will not buy biological anymore. We agree with all physicians and with patients, bear with us for 6 months, and we will not buy biological treatment unless we buy 2 and they give us 10 for free. 6 months, you could see my photo and the guy who done it in the charity wanted in most of the sales and biopharmaceutical company. 6 months, we get calls even from undersecretary in Ministry of Health. Because some physicians as well, they start complaining. We cannot prescribe medicines. 6 months later, Now we have all biological, interleukin, anti-TNF, who from medical background know that, and definitely our psoriasis association friend know that. Interleukin, anti-TNF, whatever you could think about, and we buy 2, we get 10 for free. We treat now almost 900 patients. We don't have a queue in this charity, and this is the advocacy. Advocacy is to make action. And also you need to be patient. I believe that accessibility, it's a core. I have been gifted that I am working in a private organization, but related to accessibility. I'm a board member of almost 10 charity all over our Middle East country. And there is a lot to be changed. And it needs advocacy. With all respect to the WHO and the UHC, universal healthcare, we could see the map. Where is universal healthcare and what's the progress? We cannot wait universal healthcare. We need to do an action. And don't say that, oh, okay, you are in Dubai, very rich city. It's not about money. It's just about taking action. And I could tell you a lot of stories, but the moderator will kick me now. In Dubai, how we could make from challenge an opportunity. You want to hear a story from that? Maybe later? There is something in Dubai, everyone see it these days. It was a big challenge because of some, I could say, structural and design. And even one of the government office failed to sort out the issue because of the budget needed was 4 billion dirham. It is almost $1 billion to fix this issue. Then another innovative guy, same as the charity who say, I will not buy biological anymore. He said, can you give me, to the big boss, can you give me a letter saying everyone should help me and I will make this happen and I will return money? And that's what happened. This guy, he took the issue, let us say, or the challenge. He built around that a futurist streets and a futurist building. Nothing is there. And he called in all developers. Developers start by land around this place where we don't have the money to build it actually. So they buy land around this place and they buy land equal to 16 billion dirham. So the guy then, he brought 4 billion to build actually or to sort out the challenge, and he bought in his pocket or the government pocket $12 billion. What I want to say, everyone could make from a challenge an opportunity, but it's about taking the action and keeping crying about the situation will not help, or keeping a solution which is the traditional solution, it doesn't help. We have a dating website in Saudi Arabia, but not for young people, for ankylosing spondylitis people, because there is an issue connected with the social stigma related to that. I want to say that accessibility, it is everything to let the right human reach the right quality care. Thank you.
Thank you. Thank you very much for a very provocative presentation. Next, I'd like to invite the Reach. So the question to her is, how do communities play a role in improving accessibility to healthcare facilities? Thank you.
Hi, everyone. Thank you for having me. So actually, communities are your biggest advocates when it comes into healthcare accessibility. If people believe in you, you will get that accessibility up and running in all of your communities. So it's very important to understand the socioeconomic factors for your patients. So how do you actually go about this? There are different things that you should study when you're looking at communities. You have to go out, you have to get your champions, you have to understand their background, their social determinants. And there's different factors actually that you look into when you're selecting those champions. Usually we tend to look for patients in the Patient Advisory Council based on languages, but actually it goes a little bit deeper than this. So it's very important to understand the culture aspect, their ethnic backgrounds, their religion, their beliefs, because you can see how from one culture to another, some things may differ. So for example, the role of female and male in some cultures are different. So it's very important that you bring a representative from each. In many families, the decision is not made by one single person. It's actually a family decision. So it's also important to understand those dynamics. So once you actually have those representatives, they're able to advocate for you of how you can have access to that care when it comes into your facilities. And that doesn't necessarily always mean that you have to come in physically, but rather how do you actually reach out to the communities. So it's very important that when you actually customize those policies, when you put all this work in, that you actually have people that are going to be served so that you can actually cater it to their needs. One example I'll give you, one of the things that we were trying to understand was from our Sri Lankan patients. You know, in the Middle East here, you have a very diverse community. So we've been trying to get like their feedback on different aspects of, you know, accessibility and things like this, and we never were able to tap into them. So one of the things that I thought about is actually to bring somebody that speaks Sinhala, which is their language, to see if we can actually get, you know, we can actually penetrate to their communities. And you'll be surprised the minute we brought somebody that speaks their language, the amount of feedback that we received. So it's very important to actually look at the community itself to help you bring all the feedback that you can get in a nutshell. Thank you.
Thank you very much for all the wonderful presentation. And also, I can also share a little bit some experiences in Japan. I have been thinking about the access issues, and I thought that one of the aspects we need to think is also sometimes overuse the services tests and treatment can be harmful. And also considering sustainability, we have to, that the patients and family members to utilize the available services wisely. Today, we have heard a couple of important also keywords, and that is the sustainability, because the services is very limited. So we have to also consider how we can sustain the existing services. In Japan, in one community, the pediatrician was seeing so many patients because the children's mothers, parents often visit the hospitals too many times, sometimes not necessarily urgent. So the pediatrician over there was the burnout. So he decided to actually quit the hospital clinic. So the newspaper actually caught the doctors the message. So the parents realized that the parents needed to utilize the services better, wisely. So they teach themselves when and also at what timing we need to visit the hospital clinic. So in order to sustain our existing the services, the patient's family members, community also need to consider the health conditions and also some disease treatment as well. So I guess the health literacy is another key important the topic word to sustain the existing services access issues. Thank you. Mindful of the time, our session is actually already overrun. So if you have any further burning questions or comments, I'd like to invite maybe one or two questions or comments from the audience. Thank you. All right. So without further the comment or questions, I'd like to close this session. Thank you very much for your cooperation. Thank you.
We have a break now. So about 20 minutes or so, 23 minutes. So you're requested to please be back at 12 noon. Thank you.